everyone. We're going to get started.
Yeah, they do everything. Analysis, product management.
Good afternoon and welcome to March's Grand Rounds, IGHS Grand Rounds. Well, I'm going to do my introduction and then it'll be 12:10 when you come up. But this is part of our IGHS Connect series. March's theme is tuberculosis, a topic near and dear to my heart, but we have today the privilege of one of my colleagues, Adithya Cattamanchi, speaking to us. Other events for this month, for your awareness, is on March 11th, we have an Innovation Pathways session with Dr. Suzanne Dufault in Epibiostats, who will be discussing innovations in trials methodologies. As you may recall, each month, each theme, we have an open house, or what we're calling Center Forum, where you learn about what each center is doing in public health and global health. And this month will be the Center for Tuberculosis. That's on March 18th. And then we've had our very successful Global Partner Spotlight series that will be on March 19th. That's by Zoom, 8 to 9. Join while you're commuting into work. They've been really well attended, and it's an opportunity for us to hear from our international partners and from the field. Today we have Professor Adithya Cattamanchi, who's a longtime colleague and collaborator with me. Adithya has maintained somehow double role at UCSF as being an integral part of our leadership and mentorship pipeline at the Center for Tuberculosis at UCSF, but he's also the chief of Pulmonary and Critical Care Medicine at University of California Irvine. His research over the past 18 years has been focused on the epidemiology of tuberculosis, with a particular emphasis on development, evaluation, implementation of TB diagnostics in high-burden countries. He has a unique and invaluable expertise in implementation science, which has, as I'm sure you've appreciated, become really a much higher priority investment from donors and sponsors, and just awareness about its importance has increased, in part thanks to Adithya and others at UCSF. Adithya serves on multiple WHO guideline development panels. He's on the board of advisors for the CDC TB Epidemiologic Studies Consortium and on the CDC Advisory Council for Elimination of TB. One of the things that I'm deeply grateful for to Adithya for is his really enduring and highly impactful mentorship of a pipeline of early stage investigators and junior scholars entering this field, and in relation to that, he's deeply engaged in the NHLBI K12 in implementation research and the implementation science training program at UCSF. I could go on and on, but I think I'll stop there. He's starting to get annoyed. So I'll just welcome Adithya and thank you again for giving Grand Rounds this time. Thank you.
Great, thanks, Payam. Should we check if people can hear on Zoom, or do we know that?
Yeah,
we know that. All right, great, awesome. It's great to be here. Thank you all for coming. It's nice to see a lot of familiar faces, both in our larger TB group and others, and really glad to sort of have an opportunity to speak with especially any students here and tell you all a little bit about sort of opportunities to get involved in some of our work. I titled this talk Reimagining TB Diagnosis from Implementation Science, Innovation, and Back Again. I'm going to start with kind of a bit of background, so bear with me for many of you who know this background already around TB, but then talk a little bit about our work around sort of implementation of a novel test for TB that started about 10 years ago. Use that to kind of get into sort of what we've been doing with developing novel tests, and then come back to sort of our future plans for thinking about how to better implement those novel tests. I think many of you know this, the global burden of TB is substantial. It's now the leading cause of infectious death again worldwide, briefly replaced by COVID. It's now about 10.7 million estimated new cases a year, over nearly 1.25 million deaths, and then a large burden of drug-resistant TB that's increasing and predicted to be one of the largest contributors to antimicrobial resistance deaths over the next 25 years. Yet, despite this, the problem is largely ignored. Many people, especially in the U.S., will even, when I say I'm studying TB, will ask me, "Oh, we didn't realize that was still a thing," right? And so, yes, it's still a thing, and it's a big thing worldwide, right? And increasingly, we're seeing these outbreaks locally as well. Many of you know about the high school outbreak happening here in San Francisco, and similar sort of outbreaks happening, across the country. So definitely, TB is real. We are nowhere on track to achieve NTB targets. The NTB targets, which were published in 2015, aim to reduce the incidence of TB by 80% compared to 2015 levels by 2030, and mortality by 90%. The 2015 levels are shown to the left of each graph. The middle is the current where we are, and then year 2030 is all the way on the right. And so, with the incident cases, they actually were higher in 2023 than they were in 2015, and we're obviously nowhere near an 80% reduction. And for mortality, it dropped a bit in 2023, but nowhere near as much as needs to be sort of on target to reach these goals. So why are we not on track? This slide is sort of summarized from a lecture given last year at World TB Day by Jeremiah Chikaya, right? So I think it's important to recognize that social drivers are really kind of a major force in perpetuating sort of this disease. I think many of you probably have read this book, Everything is TB. If you haven't and you're in public health, it's really a must read. It's by John Green, who's an activist, a YouTube star, an author. And in it, he writes that the disease exploits power systems that devalue human lives. And what he means by this is that over 80% of TB cases and deaths are not just in high-burden countries, but affect the most marginalized communities in high-burden countries, right? And so in terms of what's driving this, I think the first thing you have to sort of talk about is poverty, social deprivation, growth of urban slums. We know that in the US, in Western Europe, even before the availability of antibiotics in the 1950s and 70s, the burden of TB dropped substantially, right, in these places, right? And that was just because income levels rose, housing conditions improved. But today, we've really made no meaningful reduction in global poverty, and nearly 200 million or more live on less than sort of $2 a day. So until we address these issues, right, this disease is going to continue to thrive. Another sort of trend globally is the growth of urban sort of slums, right? So you have these large slums as more urbanization is happening. And now I think in many high-burden countries, over 80% of TB cases are in urban areas, right? So as we continue to have a growth of these conditions in which TB thrives, it's going to be difficult to sort of end this disease. A second key driver is that prevalent risk factors, including what's listed there on the slide, many of them are beyond the control of TB programs, and they're responsible for more than a third of cases. So malnutrition is the leading one of these, right? And you have faculty like Dr. Shete working sort of on this issue to bridge World Food Program sort of delivery along with sort of TB care. But short of that, right, without addressing malnutrition, which both increases the risk of acquiring infection, the risk of progressing to disease, and the risk of dying from disease, we're really not going to end this disease. And then last, I think Jeremiah really powerfully talked about the impact of climate change, right? Whether you believe in climate change or not, we can all agree that natural disasters are increasing in frequency. They're more intense. They lead to more displacement of people, which further worsens poverty, which then further drives transmission and disease vulnerability, right? So for all these reasons, it's that's why I think TB is such a fascinating disease and a great thing to kind of think about as you're studying public health, right? It really encompasses both sort of biomedical, sort of public health, but a lot of sort of social factors that sort of drive this disease persisting. You might hear all that and say, well, many of those things are things that I'm not going to be able to address, right, in public health or with biomedical interventions. And I think that's okay, right? There's still a large cost to inaction, and this is a slide from the NTB report. And what it shows is that, the red line is kind of what is expected to happen with TB cases if we sort of just continued along the current path. The green line shows what we could achieve with better implementation of the current tools that we have. We can avert over 16.8 million cases over 8 years compared with kind of just doing what we're currently doing. And then, the blue line shows if we have to develop new tools, right, better diagnostics, which we'll talk about today, perhaps even a modestly effective vaccine or shorter treatments, right, we can avert an additional 26.5 million cases. So yeah, it's still important to sort of address this disease from a public health and biomedical standpoint, and we can be doing a lot better. So in terms of sort of why, current implementation of current tools is important, right? So the TB care process is really sort of a maze, right? When people enter that process, right, with symptoms perhaps starting to seek care, there's many sort of dead ends, right, and wrong turns. And many people, it either takes a long time to get out the other side and be successfully treated, and many people just get lost in this maze, right? And so the graph on the right shows, what's called a care cascade, right? So it talks about sort of where do we have losses along the processes of care that are required to diagnose, treat, and cure someone with TB. What you can appreciate is that diagnosis is by far the largest gap, and nearly half of people with TB are lost before they're diagnosed and linked to treatment, right? And so if we're not even finding people and treating them, right, we're not going to be able to make a dent in sort of reducing transmission and sort of improving outcomes. So that's been sort of the overall focus of my research group, right, is bringing these things together. How can we improve TB case detection and linkage to treatment? And, our group really focuses on better diagnostics, but also sort of how can we deliver them in a way that improves access and leads to strengthened health systems, right? And all three are really needed to achieve this goal of increasing TB case detection. So I'm going to start again, kind of a journey. When I started on faculty in 2010, this new test came out. It was called Expert MTB RIF. Before that, right, we didn't have any easy-to-do PCR tests for TB. It required the large, semi-quantitative, quantitative PCR machines and lab expertise, etc. Excuse me. So this was the first test that was semi-automated. It was cartridge-based. It required minimal training, and it could be done, by relatively, minimally trained sort of laboratory workers in high-burden countries. So this was endorsed by the WHO in 2010. It detects both TB and rifampin resistance in just 2 hours, with much higher sensitivity than sputum smear microscopy, which was the test that was being used, and very high specificity. And so this was, exciting. It was, in an editorial at the time, was called a potential game changer. There was rapid scale-up and significant donor and country investment in this technology. This is just, again, shown in the first sort of 5 years, or even 4 years, right? Nearly 4,000 instruments, almost 10 million cartridges were procured, and the curve was just going sort of rapidly steep up, right? And there's a huge expectation that it's going to have a large impact. Uganda was a place I was working at the time, thanks to one of my mentors, Dr. Lawrence Wong, who's I'm grateful he's here today. And in Uganda at the time, it was a global leader in molecular testing scale-up, right? It had procured over 200 gene expert devices and more than 400,000 cartridges. It had deployed them in a hub and spoke model. In the graph there, you see in red all of the gene expert hubs that they had created across the country. So in nearly every district, there was a gene expert testing site. By hub and spoke model, what I mean is that the hubs were the gene expert testing sites, and then the spokes were the other health centers in that region that either referred samples or sent patients there for testing. And if you look kind of anecdotally, right, at outcomes before 2010 and then in the first 5 years as the scale-up was happening, you get some sense that it was having an impact, right? There was a nearly 4-fold increase in MDR TB cases. There was an increase in the proportion of bacteriologic confirmed cases from 60 to 65% to a little bit more than 70%. And there was a slight uptick in TB case notifications, right, from the low 40s to the mid 40s, right? So all potentially positive signs that this was having some impact. But at the time, there were also a lot of unresolved questions, right? How well are these expert hub and spoke referral networks functioning? What's the quality of diagnostic care within these networks? And are there policy changes or co-interventions that could further enhance expert implementation And not just expert, but that of future sort of rapid molecular tests, as we'll get to in a second. So at the time, we designed a series of studies, which eventually became called EXPEL-TB, which stands for Expert Performance Evaluation to Facilitate Linkage to TB Care. The aims were to quantify the gaps in TB diagnosis at health centers linked to expert testing sites, to identify modifiable barriers to high-quality TB diagnostic services at a provider, patient, and health system level, and then to develop and test theory-driven interventions to improve the quality of diagnostic services. I'm going to summarize a lot of work fairly quickly, but for aim one, we wanted to first just define what we call the quality gap, right? So we picked 24 health centers in Uganda that were spokes that were linked to 16 gene expert testing hubs. We just selected these based on having reasonable TB case notifications. And we designed a prospective cohort study of all adults who are undergoing TB evaluation. And TB is a reportable disease, so anyone who gets tested for TB and who has a positive test and is treated, those are all in sort of standard national registers. So we developed a system to take photos of those registers and extract data from them to understand what was happening to everyone who was referred for TB testing, and then sort of what happened to them during the testing process and whether they were linked to care. So this is the one of the first studies we published, and this was around 2,500 adults who were undergoing TB evaluation at the study site over about a 1-year period. The first indicator is how many of them were referred for sputum-based testing, right, which is what's recommended for anyone who's suspected of having TB. And that was about 80%, right? And then the second indicator was of those who were referred who completed testing. So at the time, that meant either getting 2 sputum smears done or having your sample sent to a expert hub for expert testing. And that was only 55%, right? And then the third indicator was that if you had a positive test result, either a sputum smear or expert, were you treated, right, within 14 days. And that was about 73%. So what that means, though, is that if you were a person with TB who was entering any of these facilities, on average, you had a probability of being diagnosed and treated of just 33%, right? So despite having high coverage of expert testing, right, the actual ability to get a diagnosis and treatment was not that great. There were other issues, right? Only 17% of patients were even referred for expert testing, including just about a third of those with HIV for whom it should have been a first-line test. Less than 5% of patients referred for expert as a first-line test, so they were being told to get microscopy. If that was negative, they would come back, have to get test referred, come back again for test results. So not surprisingly, a lot of people were lost, right, in that care maze. And then, less than half of expert-positive patients were actually initiating treatment. Again, getting back to the idea that the process of TB care is a complex maze. So again, just high coverage, which is what often we talk about in global health especially. What's the coverage of various interventions, whether that's interventions for maternal and child health or others, right? It doesn't really mean that high quality of care is occurring, right? So we need to look beyond coverage and actually look at sort of care delivery to understand what's happening. So for aim 2, we wanted to understand the quality gap, and here we used a kind of implementation science approach. Here we picked a particular behavioral theory called the theory of planned behavior. The details of the theory are not very important, but in implementation science, we use these theories to help us to guide instructor data collection in order to sort of understand sort of the problem. And so here we posited that knowledge, skills, attitudes, social norms, and the self-efficacy of health workers would predict their intention to follow guidelines. And then based on those who had intention were more likely to follow guidelines, which would then ultimately lead to case detection and treatment. Because we're working in sort of a high burden, low resource setting, we also wanted to collect data on patient factors and health system factors that could mediate going from intention to actual guideline adherence. So this is kind of a quick summary of a number of qualitative studies that we did. They're all cited on the bottom. And they're summarized according to another implementation science framework called the PROCEED framework, which helps to move from theory to action, right? So this framework suggests that for complex interventions, they should target factors across 3 areas: predisposing, enabling, and reinforcing factors. And so for us, the key predisposing factors were time and resource constraints, resulting due to a high workload, particularly of laboratory staff, and that led to sort of a low sense of self-efficacy that they could do TB testing rapidly. There was also a pervasive belief that TB evaluation is not urgent, right, which was completely opposite of a kid with a fever who came in with possible malaria. There, they got the blood test right away, and if it was positive, they made sure the kid was treated. For TB, there was just this sense historically that, oh yeah, you can send them home, they'll come back whenever. If they don't come back, maybe they'll come back later, we don't know, right? That was just the attitude sort of what was going on with TB. Enabling factors, right? Again, the patient, we learned this very quickly in all of our work, right? It was very difficult for them to return after their initial visit to a health center. This is, again, work that Priya led, right? That because of time and cost, right? It costs people nearly half of their median monthly income to complete a health center visit, right? So, of course, they're not going to come back again to get test results, or a third time to drop off specimens. There was also inconsistent and delayed specimen transport to expert sites. Health centers didn't have the ability to track and follow up patients, as we talked about. In terms of reinforcing factors, one of the big things we heard was that there was very little communication and coordination, right, between staff. They didn't really understand where the problems were, what the gaps were, what they needed to address, and they had insufficient oversight from the NTP. So these are the things that we wanted to address. And so to do that, we went through a process where we reviewed evidence on what types of interventions were helpful for addressing these types of barriers. We consulted with stakeholders locally, predominantly to think about sort of feasibility of various types of interventions that could be done. And we worked with them to prioritize barriers, select interventions, and specify how those interventions were going to be delivered in this context. So what we came up with was this Expel TB strategy. So at the time, there was a next iteration of a Gene Expert device. It was called the Gene Expert Edge. It was battery operated, so it could be placed at lower level health centers, like the ones we were working at. It was encased in this blue dust-resistant kind of cover, which again made it sort of operable in more harsh environments outside of air-conditioned laboratories. And so the goal was to use this on-site expert testing as a replacement for sputum microscopy at the health clinic level, rather than the hub-and-spoke model. And the goal was here to address barriers relating to reduced workload, increased speed, and the accuracy of testing. But in addition to this technology, right, that doesn't address all of the other barriers that we talked about, right? So we included also using a quality improvement process to facilitate same-day testing and treatment. That sounds complex, but what that really meant was just working with each health center to help them realize that what's happening at your health centers is that a patient is coming in, they're asked to sit and wait, sometimes 4, 5, 6 hours to see a clinician, right? And in that time, you could have had, and you should be actually doing infection screening for cough. If they had cough, you could have asked them to go to the lab and get a sputum. So by the time they're seen by a clinician, the sputum result is available. So it actually is a very low-cost intervention, and most sites actually figured out very easily sort of how to redesign their workflows to prioritize infection screening or cough screening, which was supposed to be part of infection control guidelines, and then get people tested so that the results were available to the clinicians. And then again, as part of sort of improving communication, what we did was we extracted data from the registers and just fed them back as quality indicators, the same indicators I showed you previously, to help, and then taught them to review the indicators and think about sort of interventions and talk about interventions they could do to try to sort of address whatever they thought was leading to the indicators not being at target levels. So we were fortunate to get funding to do a cluster randomized trial of this strategy. This was, the objective here was to evaluate its effectiveness, implementation, and cost effectiveness. The figure shows the two kind of interventions and routine care. So the diagnostic strategy, the intervention strategy was what I just described, on-site molecular testing as the first-line test using Gene Expert Edge, streamlined clinical and laboratory and pharmacy workflows to enable same-day treatment initiation, and then monthly performance feedback indicators. And routine care was what was happening, right, which was sputum stream microscopy as the first-line test, and referral of certain patients to molecular testing hubs for expert testing. So again, we were looking at 20 community health centers in Uganda, and we evaluated, similarly collected data on all adults evaluated for pulmonary TB from 2018 to 2020. I don't know if I highlighted this here. I kind of left this part about, one of the things I want to highlight about this trial, just as from an epidemiologic standpoint, is that this is one of the most pragmatic trials in TB. And I'll get to it included over 10,000 people, which is probably the largest trial of TB diagnostics ever done. And the reason for that, and the reason I'm highlighting this, is because I think if we really want to understand how interventions are done in care, we really have to move toward more pragmatic trials. So what do I mean by that, right? So for this trial, right, we intentionally designed it so we had no staff at any of the health centers, right, other than visiting quarterly to sort of collect data and do sub-studies. All of the data collection relied on existing health center data, right, the TB registers. We didn't introduce any new systems which themselves might sort of change care, especially sort of routine care. We didn't add any procedures. Oftentimes studies will want to do culture or do x-rays, right, because they want to understand what's going on. But all of those things, lead to sort of changes in what's happening under routine care, but also sort of lead to sort of more research staff sort of doing sort of more and more things, which sort of doesn't allow you to study what's happening actually at the health center level. I just wanted to highlight sort of that this as a sort of a highly sort of pragmatic trial. As I mentioned, there was 10,644 participants, and what the results show in red is the primary outcome was the number who were treated for confirmed TB within 14 days. There was a 56% improvement in that count. At 14 days, all of the other secondary outcomes were also improved, and the improvements were even more substantial if you looked across the care cascade when you look at same-day outcomes, right? So the number who were tested according to guidelines, were diagnosed with confirmed TB, treated on the same day, and for either for confirmed TB or for TB overall, all of those sort of improved substantially sort of during the intervention period, or at the intervention health centers. But of course, right, that comes at a cost, right, and that's always sort of an issue for sort of global health in particular. So as cost-effectiveness studies do, we looked at the incremental cost-effectiveness ratio, and if you stop there, right, I mean the additional cost per TB diagnosis was modest, about $1,300. And the additional cost per person treated rapidly was even lower at $687, right? So all very reasonable if you look at sort of willingness to pay thresholds. But the problem is budgets, right? The cost per patient tested doubled, right? From under $10 to sort of over $20, right? So essentially you're telling TB programs that you'll have to double your budget for diagnostics if you want to sort of implement this sort of decentralized sort of molecular testing, which was a non-starter even before the global health funding went to hell over the last year or so. So I think the bottom line is, despite all of this effort and careful implementation work, millions of people still don't have access to a rapid TB diagnosis, right? So we've done all this research, done all this tech development, but what impact is it actually having? And so if you look at the Global TB report, this was last year's report, but the 2025 report is similar. Less than half of TB diagnostic sites worldwide had access to WHO-recommended rapid tests in 23 of 30 high-burden countries. A rapid diagnostic was used as the initial test in less than half of patients. Only 62% of pulmonary TB cases were bacteriologically confirmed, and about 80% were actually tested for rifampin resistance, right? So clearly, I think we know now that decentralized rapid molecular testing could have a big impact, but what we need is more accessible, simpler, and affordable TB diagnostics. So I'm going to switch gears to another sort of portfolio of work that we're involved in, which is really reimagining rapid diagnostic tests for TB. So the first part of that is we need better technology platforms, right? We've moved from microscopy to sort of molecular systems, but we need molecular systems that are more near patient or even point of care, as we have for COVID and HIV and other viral diseases in particular. And we need to move from the antigen tests like urine lamb that we currently have that are not very sensitive to next generation antigen tests that are able to achieve much lower analytical limits of detection. But beyond sort of technology platforms, I think we also need to think about sort of moving beyond sputum, right, as the only way or the main way of diagnosing TB. This is work done by colleagues of ours in Heidelberg, but this is a systematic review that looked at different groups, those with adults with presumptive TB, children, in the context of active case finding and household contacts. And what we find is that sputum scarcity is a real problem, right? So even among adults who are coming in symptomatic, about a quarter are unable to produce sputum. If you look at children less than 5, that's 97%, right? We're just not diagnosing children, right, microbiologically right now, young kids especially. And if you look at other groups, again, it's about around 30%, right, are not sort of able to produce sputum. And so I think we need to move beyond sputum, right, and things like stool, which for children is essentially just swallowed sputum, to other sample types that are much easier to collect and analyze. So we've been, again, fortunate to get funding to support the advancement of novel sort of non-sputum-based tests. And we call this network the Rapid Research and Diagnostic Development for TB Network. I have to give credit to Payam's son, who named it the R2D2 TB Network, which has turned out to be highly fortunate evolution, if we don't get sued, of course, for any violations. I think this is the best logo that we've ever come up with. It's definitely, and I've also realized the importance of having a good title and logo in terms of how your study is seen and viewed worldwide, right? Everyone just remembers this, right? This name and this logo that's really helped us to develop a worldwide brand in sort of TB diagnostics. Not just with public health folks, but with companies, right? Which I'll tell you is really important for this work. So the aims of this grant were to solicit and prioritize novel TB diagnostics for evaluation. So we have a whole team that's based in Heidelberg with Claudia Denkinger, who was the previous head of FIND in Geneva. And their team works to through database reviews, attending conferences. They've developed a database of over 600 companies with technologies that could potentially be applied to TB. And many of them are working with them to sort of conduct either early studies and some of them later studies of novel tests that they've developed. And so what we do once we identify products is that we conduct iterative studies of early stage tests to provide feedback to developers on how whether their current version is meeting targets, what might need to be improved. As they get advanced to sort of design lock tests, we conduct multi-center assessments to facilitate WHO policy review. And then we have a group of folks who are focused on looking at costs of novel TB diagnostics, but also algorithms, including sort of novel tests. I think what's unique about this study, it's sort of an adaptive diagnostic accuracy sort of approach using platform designs and Bayesian decision-making, which was really sort of the brainchild of Patrick Phillips, who's also here today. And what we do is we have a specific group of patients, like adults or adolescents and adults with TB, or children with TB, or people with drug resistance, depending on the type of test we want. We have comparator tests, right, that we always do, and that's the current tests, Expert Ultra and smear microscopy. And then we conduct multiple novel test evaluations simultaneously, right? So we're able to add and drop novel index tests continuously throughout the protocol, and that allows us to cycle through as many tests as feasibly the labs in the countries we work with can handle. Over the last 5 years, I think we've looked at more than 50 tests across about 7 countries. So I think it's a major sort of advance in sort of from going from many studies before, which were just designed to solely look at sort of one test, and it would take 3 or 4 years to just complete the evaluation of that one assessment. We're fortunate to work with partners who really operate world-class TB trial sites in multiple high-burden countries. Our sites are distributed across Africa, West Africa, Nigeria, South Africa, Zambia, and Mozambique for kids, and then Uganda and sort of East Africa and Asia. We have India, Vietnam, and the Philippines, and then Georgia is a site in Eastern Europe that has incredibly high levels of sort of drug resistance. One aspect of our work, and that's related to advancing oral swabs as a novel sample type for TB diagnosis. And so I'm going to focus on oral swabs, one, because I think that's the work that's advanced the most, but it's also, I think, representative of sort of what we're trying to achieve with non-sputum-based testing. A key advantage of oral swabs is that they're easy to collect from people of all ages, right? And we somewhat know this from COVID, but now we've looked at this in the context of TB as well. So we've shown in preference assessments led by sort of Andrew Kirchhoff and Nora West that these are easy to collect from people of all ages, and so they're preferred over sputum collection. So about nearly 60% preferred tongue swab collection compared to 20% for sputum and 17% with no preference. People also report that they're easier sample to provide, right? Overwhelmingly, about 74%, and they're much less likely to lead to discomfort than sputum production, only 10% versus 51% for sputum. That said, I think there are still, the qualitative insights are interesting, right? So I think people recognize that it's easier to collect, it's more accessible, it'll be more available. But at the same time, there's in terms of challenges for implementation, what we learned is that there's an inherent trust in sputum, both from health workers and patients, right? It's from health workers, it's what they've been trained on, it's what they think that they've been doing. For patients, they feel like it's more directly related to kind of a disease in their lungs. So we have to kind of overcome some of those hurdles in terms of educating both health workers and patients in order for swab-based testing to have sort of high uptake. In addition to kind of that work, and we've done, we and others have worked together to do a lot of work to learn quite a bit about how to develop a swab-based molecular test for TB. For those of you in other areas, whether it's HIV or COVID or other viruses, TB is different, right? With a viral disease, you have millions of copies of virus, right? Lots of DNA, so much easier to detect. With TB, there's many less bacteria. The bacteria are encased in a very dense cell wall that's hard to penetrate. So there's a number of things that are different about testing for TB than testing for viruses. So what we learned is that the swab type matters, right? For TB, you need to use a swab that collects as much biomass as possible, right? And so different types of swabs, collect different amounts of biomass, right? So that's one area of standardization in the field that was needed to move to sort of the most effective swab types. Second, we learned that swabs are stable in dry or in buffer, even at elevated temperatures. So that's really important for something, for example, like for community-based screening, right? You can collect a dry swab, and you don't even have to put it in a fridge, right? It can stay stable at room temperature. We learned over time that tongue swabs, especially the dorsum of the tongue, has higher yield than other nasal or oral swabs. And again, we postulate the mechanisms that when people cough, TB bacteria are deposited on the back. If you have TB, they're deposited on the back of your tongue. So that's the area now that we focused on for sample collection. We've also learned that heat and mechanical lysis are required to achieve high clinical sensitivity. So these are, again, when we work with developers, we talk to them about incorporating these into their testing workflows. On the other hand, nucleic acid extraction and purification, which is always necessary for sputum-based testing, is not needed, right, for swab-based testing. And that's good because these steps add cost and complexity. And then last, one of our staff in Uganda interestingly just tried taking a swab and swirling it in sputum, and realized that that works with the same sort of platforms that were originally designed for tongue swabs. Right? This is not even something that the developers were picked up on. And what's nice about that is that now you can have one platform that can test a sputum sample if someone can produce it, but now can also test a tongue swab if someone can't produce it. So that was a really great observation made by a team member in Uganda. So all of these lessons are being put together by various companies that we're working with. The most advanced, and the one I'll talk about today, is this test by Plus Life, which is a company from China. They've developed a very small device that was really developed for COVID. You see on top, it's kind of almost the size of my cell phone. It fits in the palm of my hand. It's battery operated, integrated with a battery on the bottom. And then they developed a simple sort of lysis machine, which again can be operated by battery. And together, right, these form sort of the Minidoc MTB testing system. It's also a very simple workflow. You collect the sample, either a sputum, a swab dipped in sputum, or a tongue swab. Right, you insert it into the tube, and as we do with COVID, we're used to squeezing the tube and turning it, and then you just insert it into the lysis machine, and then the tube has a dropper at the end of it. You drop a certain amount onto the test cartridge, insert it into the device, and you have a result in less than 35 minutes with less than 2 minutes of hands-on time. And the cost, this is I think the most remarkable thing, right? The per test cost is less than $3 compared to $12 to $15 for a gene expert test, right? And the cost of the instruments, the two together, is $300 compared to $12,000 for a gene expert instrument, right? So finally, we're at a test that is, in some ways, actually cheaper than a LED light microscope used for sputum smear microscopy. So this is a huge development, and we're hopeful can lead to an actual game changer where we can make molecular testing more accessible. But of course, first we need to show that this works. And so that's what many in this room have been involved in sort of doing over the last year. These are results from a multi-country diagnostic accuracy study of this platform. We included about 1,380, so nearly 1,400 patients. You can see there the eligibility flow chart. So of these patients, nearly half were women. Most of them were symptomatic. About 20% were living with HIV. And they had a variable sort of distribution of TB burden, right, based on sputum expert ultra results, right? Those who had a very high burden, but then quite a number that had low or very low burden of disease, at least based on a semi-quantitative sputum expert ultra results. So these are the key results. I think there's a lot on this slide, but if you the first row compares the sensitivity of a sputum swab with a new test against culture, and you see that the sensitivity is 86.7% and specificity is very high at about 98%. For sputum expert ultra, those numbers were similar, so that in fact there was actually no significant difference in sensitivity between sputum expert ultra testing and testing of the sputum swab using the Mini-Doc platform. And the sputum swab was much more sensitive than sputum smear microscopy, right? So again, now you have a low-cost molecular test, which can be done, in any health center that's much more sensitive than microscopy. For tongue swabs, they're a little bit less sensitive than sputum swabs at 80%, again with high specificity. As expected, they're less sensitive than sputum expert ultra, but they're much more sensitive than sputum smear microscopy. The takeaway is that both the sputum swab and tongue swab, they exceed minimum WHO target product profile accuracy targets for TB tests. And in terms of cost effectiveness, I think what's really interesting is that when we again, this is work done by colleagues in Heidelberg, but what we show is that when you do in comparison doing tongue swab Mini-Doc only, it's minimal additional cost to do a combined strategy where you test people first with a sputum if they can't produce it, and then a tongue swab, and then the sputum expert ultra is just dominated, right? So it's not even, in no scenario does it sort of perform better if you look at the figure on the right. So again, we have a test that is pretty much as effective and much lower cost, and because it can lead to many more people being tested, it really dominates the current paradigm for TB testing. So I think this is just hot off the press. So just last week, the WHO finally announced their guidance. And so they used to issue rapid communications, but I guess now it's just website updates is how they're communicating, which, I don't know, pretends maybe other budget cuts that are happening there. But I think for us, this is very exciting. This is the recommendation is written. It's for a new class of TB tests, which they call near point of care or NPOC nucleic acid amplification tests. And they're recommended to be used as the initial diagnostic test for TB rather than sputum smear microscopy. And they recommend that if you can't obtain sputum, you can do these tests using tongue swabs, right? This is exactly what we were hoping for, and the full guidance is is pending, but now sort of countries are ready to sort of start implementing it if they choose. So I think what's been fascinating about this work is that there's so much excitement in the TB community about these tests, right? And so normally you go from a review process to a guideline being issued 6 months later, and then maybe countries will take another year or two to figure out what they want to do locally, and then maybe it'll reach the global fund, and eventually 4 or 5 years later you'll start seeing some rollout. Here, what we're saying, even before the guidelines came out, the Global Fund committed a large amount of money to support 15 countries to do a massive rollout of these technologies, this technology at their low-level health centers. And I think that's remarkable, right? So this is supposed to start now in Q3 of this year. So for the last 9 months, even before the guideline came out, the countries in the Global Fund have been planning together to develop implementation plans and to sort of verify procurement chains, all of those things. And I think what's exciting for us is that we are in the final stages of discussion with the Gates Foundation to lead an impact evaluation of this global rollout. And that's where I'm saying it's coming back to implementation science, because yes, now we have the technology, but we really need to understand how can this actually be implemented successfully at scale, right, in settings where TB testing has never been done before. But again, another sort of exciting, but that's an exciting problem, one that I'm excited about now that we have this technology. What's also exciting is that through this R2D2TB network and other efforts, there's now a large pipeline of molecular diagnostics, so not just this Pulse Life test, but many other sort of near point of care tests that we expect will become available in the next year or two. And there are even a couple of truly point-of-care tests that are instrument-free that are in early stages of development. So I'm hopeful that in the next 5 years, we'll get closer to this idea of either kind of a home test or a self-test for TB. But we're still a ways away from that. So I think that's my last slide. Yeah. So just to conclude, TB is still thriving as a global public health threat, driven by social injustices and service access barriers. Better implementation of current tools in a manner that reduces access barriers and improves quality of care can have substantial impact. And then I think what's really exciting is that these low-cost, widespread molecular testing is finally close to becoming a reality with slot-based platforms, and we're hopeful that they'll accelerate progress towards NTB targets. There's too many people to thank to list them on a slide, and so I'll just say, really grateful to the study teams that were involved in this work, and not everyone is shown in these pictures, but this really a large number of people across many countries that contributed to this work, and of course funding from the NIH, the USAID, Gates Foundation, and Global Health Labs. I'll stop there. Questions? Don't be shy. Fine.
It's a very nice description of a journey that I think you're very pleased about the success that came out of it for the near point of care test. Could you describe a little bit on the pipeline of possible new, emerging diagnostics? What are the key motivating drivers for companies to even consider working in TB?
Yeah, I think it's a great question, right? So one is that, I think what we've realized is that, a significant amount of money was invested during the COVID pandemic, right? Billions of dollars in developing new tests, molecular tests in particular, but also sort of antigen-based tests. And these, and many small companies, were awarded sort of money, and they developed, products. But now, COVID testing has just plummeted, right? Hardly anyone is testing for COVID anymore. So now you have all of these developers and platforms that are looking for other tests to do, right? And so we've been able to attract many of them to TB as one, possible sort of way. The reality is that, the TB testing market is substantial, right? Hundreds of millions of TB tests are done worldwide sort of every year. And so I think companies are realizing now through a lot of education, again, done by our team in Heidelberg, that this is actually sort of a viable market to get into. And I think what we're going to see is kind of regional diversity, right? Where you have manufacturers and companies in Asia who are maybe supplying a lot of the Asian sites, some also going to Africa, but we're also seeing now sort of a lot of manufacturing happening in South Africa and other places. So I think, what's been challenging over the last 10 years is reliance on a single manufacturer, right? GeneXpert, based in Sunnyvale, right? And so any issues with production, any changes in politics, like for example, Cepheid was bought by Danaher, a large holding company, which for a while decided it was going to move away from TB. So it actually stopped production of the GeneXpert Edge platform that I mentioned, for example. So these kinds of things you're liable to, right, when you're relying on one developer. And I think what I'm hopeful for over the next 5 years is that we're not going to be in that situation anymore. We have a number of developers who are actually competing, right, both based on price and quality, and sometimes based on politics. So, India wants a manufacturer from India, et cetera, right?
Adithya?
Great, yeah.
Good to see you. So I have a question, and I'm not a TB researcher, as you know, but I have worked a lot with HIV. I was really, struck by what's happened around incidence and the number and prevalence of TB. Basically, it's not going well, and perhaps these new tools will help. I'm just wondering, though, you also mentioned that certain populations, like urban populations and crowded conditions, are higher risk. You know about the SEARCH trials, obviously, run by Moses Kamya and Dan Habler and others. Have you worked with modelers to look at other approaches, like community-based approaches, picking up latent TB, infectious TB? And also I have a question, how would these tests what would the sensitivity be in a latent case, a not active case? I'm assuming it's going to be lower, but could you foresee a world where really incidence able to go down? Were you able to go to the high-risk populations and really bring the incidence down of TB, which then would worldwide have a huge impact? Because what we're doing so far is not working.
Yeah, no, 100%, right? I mean, there are studies going all the way back to the 60s, and like, George Comstock and others, right? People who were founders in epidemiology, who showed, like in Alaska, right? If you can combine effective mass community-based screening with X-ray, with linkage to TB treatment, and then linkage to treatment for TB infection, right? So INH back in the day, you can massively reduce TB incidence, right? And that's now been repeated. Right? It was shown in Vietnam by Guy Marks and Greg Fox, where they did a similar study in the modern era in communities in Vietnam. Again, massive reductions in incidence by combining those interventions, right? Active case finding, right, with chest X-ray, gene expert testing to identify active cases, and preventive therapy, right? So we know what to do, right? But the question is, like, is it feasible to do with the current tools we have at scale, right? And I think many programs are concluding that it's not, right? It's not easy to implement mass chest X-ray screening programs, right? It takes the infrastructure to do that, including the X-ray machinery, is not quite there. It's getting better. Now we have CAD algorithms, like all of these things, I mean, they're starting to get there, right? For preventive therapy, right, it's still very difficult to get people to take treatment for, even 12 weeks or longer, right, if you're feeling healthy, right? We can't even get that to happen for immigrants in the US who are eligible for preventive therapy. So I think we still need shorter regimens, which, folks, are working on, but we're getting closer to all of those things. And the last piece of it is the diagnostics, right? So I think we need tests, you can go and test people in the community. If you're collecting their sputum and you're transporting it back, you need a way to get the result back to them, right? And actually have them linked to care. But now, again, with at least that part of it, I'm hopeful with these types of tests, we can actually do the testing on site within 30 minutes, right, where people can wait for their result and not have to and then be linked to care, right? For the screening part of it, there's actually, I didn't talk about this part of our work, but we're doing a lot of work with looking at using AI-based approaches to listening to lung sounds and cough sounds is a much simpler way to screen for TB than chest X-ray, right? So I guess what I'm saying is we know what to do, but the tools to do it at scale, I don't think are quite there yet. But I'm curious what others in the room think.
I have a question from Judy Hahn. I just unmuted her. Judy?
Hi, thanks. Thanks, Adithya. Great work. Just because you're so well connected, I wanted to ask what you think our U.S. government is thinking about TB these days. Are they interested? I'm very perplexed by, the push to do implementation science, but that's context specific, and where TB is not, for the most part, necessarily the U.S. So how do those work together? Do you think that there is a future of, U.S.-based collaborations with, where places where TB is funded by our government? Thanks.
Yeah, thanks, Judy, and thanks for joining as well. It's a great question. I was pessimistic about this for a while, but then, on the other hand, I mean, I do think there is, at least within parts of, the government, that people do care about TB, right? And they're still releasing TB-specific RFAs, right? The TBRU one is a good example, and there's others. And so I think people still recognize that TB is an important issue. I think things that are going on in the news, including what's happening in San Francisco, I think there's another outbreak happening in Philadelphia in schools, all of these things are, keeping it sort of in the news. But I do think from a research standpoint, there is an emphasis on, wanting to show, as for all foreign research, like what the benefit is to U.S. Communities. And I think we're fortunate here in California to have many years of close collaboration with the California Department of Public Health, as well as local health departments, whether that's in San Francisco or in other areas. And I think more and more there are folks, thinking about, how can we leverage those networks to study some of the things that we're interested in. I know, a colleague at Emory, Sarita Shah, she's actually working with, several jurisdictions in California, and she moved her R01, which was originally in South Africa, which obviously you guys know can't happen, so that was moved to be working with CDPH here, right? So I think there is an opportunity, but not just an opportunity, a need, right? An interesting paradox is that we're developing all of these new tests for TB, right, that are going to be available worldwide. But now we're behind in the US, right, because many of these companies are not interested in going through FDA approval, or they don't have they're not going to dedicate money to that, right, to do the studies in the US. And so we're still stuck with the old version of the GeneXpert. We don't even have the new version of GeneXpert as a test in the US. So I think there's a need for us to figure out how we can advance some of these tools in the US and to work, with the jurisdictions that we have, the health systems that we have to try to sort of advance some of these tools in the US as well. I don't know if that totally answers your question, but I think Pine, you can also speak to the US government's interest in TB. You've been to the Hill more recently than I have.
No, I think you summarized it well. Considering the cuts that the NIH and CDC have faced, tuberculosis, for the time being, seems to have had a bit more protection, but it is all very precarious as it pertains to public health research and development. I think one attractant is American companies are behind some of these R&D, new tools, new drugs, new vaccines, and that has some appeal to decision makers in the administration. Okay, that's it.
I promised one more. There's several, but I know that we're at time. But one from Bassam Ghali. By expanding point of care and molecular tests, are we losing capacity for culture and resistance data? Does this even matter?
So that's again another great question. So one limitation of this test that I mentioned is that it's a qualitative test, so it doesn't, one, provide a semi-quantitative value, but two, it doesn't test for rifampin resistance at the same time. That's partially being addressed. The company is actually working on a rifampin resistance reflex test that can just use the leftover swab residual. So hopefully that'll be addressed soon. But I think regardless, I don't think any one test is going to solve every need, right, for TB diagnostics. And we need to stop waiting for that magic bullet, right? Testing for drug resistance in TB is complex, right? It requires, at this point, a whole genome or targeted sequencing to look at a large number of potential resistance loci, across many parts of the genome. So I think that's still best done at reference centers, right? And that's where sort of culture-based DST and targeted sequencing happen. Most people with drug-resistant TB, also the treatment is complex. So the treatment is still largely outside of, at sort of specialized centers that have access to these tests. So no, these tests are not a replacement for those. They're going to help to diagnose more TB. We do need to sort of make sure that rifampin resistance testing is still happening for those who are identified as positive by this new test. And then, for those who have rif resistance, continue to refer them to the more central sort of facilities that specialize in care for drug-resistant disease.
I have 3 more questions, but you can also.
I mean, I don't want to keep people here, but I'm happy to stay.
Okay.
Can I ask?
Okay. Yeah.
Thanks, Adithya, great talk. It's nice to see the full art. Chaim alluded to this at the beginning, but also just conscious of the audience that you have. Do you have any suggestions for 2 things? One, if you are an early investigator, a student with interests or undifferentiated interests, what to do, how to get involved, good first steps to kind of get involved in TB research. And the second is, if you are faculty or you're involved in TB research or in other fields, I think one thing that I've benefited from is your mentorship and developing a mentorship portfolio that's kind of on par with your research portfolio. Do you have suggestions for how to do that well from first-being mentors as well?
30 seconds. No, because it costs from.
Yeah, I think we should. The second part we can talk offline. But the first part, I just wanted to highlight to students, right? I mean, this is still a huge public health problem. So yes, we need more students, more young people involved in this space. And the current trends and the current administration, they're not going to be there forever, right? So that will change, and things will sort of keep changing, right? So I would say if this is an area you're passionate about, particularly public health and global health, TB is a great thing to be.
Do you have a classroom that's
Thank
coming
you.
in?